Now I request Dr. M.K. Rai, who is one of our course directors, to introduce our chairperson and also Mr. Dr. Kaushik Samanta, who will present the case. And then you will also introduce Pinaki Mukherjee, who is the chairperson of this session. Mrinal Rai, please.
Thank you. Good morning and Happy New Year to everyone. Today, we are going to have a very interesting topic, that is the nephrotic syndrome, which will be discussed by a real case scenario. And for that, we have got a doyen in this field of nephrology, Professor Vivekananda Jha, who will be interpreting the different facets of this particular problem when the case will be presented. So this will be a very new thing today. It's a case-based discussion. For this, we have got our Professor Pinaki Mukherjee, who is a renowned neurologist in the eastern region of this country. And we all know that he is at present the professor and head of the Department of Nephrology, NRS Medical College, Kolkata. He is very close to us, and he is a very active member of Association of Physicians of India. And it is due to his endeavor and effort. You all know that presently the NRS is also doing a lot of renal transplant, and he is the leader of this stage. So a big congratulations for Professor Mukherjee in this regard. Without wasting much time, I like to tell you that this presenter will be Dr. Kaushik Samanta, the third-year senior resident PGT from Arjigor Medical College, who will be telling us the different aspects of a case, especially presenting to their OPD probably or in the indoor basis as the nephrotic syndrome, and which will be later on discussed and interpreted by two doyens in the field of nephrology. And with these few words, I now hand over to Professor Pinaki Mukherjee with the request that he will introduce the speaker, and I mean you will introduce the chairman, Dr. Jha, and also the speaker of this session. Over to Dr. Mukherjee, please.
Good morning, everybody, and Happy New Year to you all. This is my privilege. That is, I am going to introduce my mentor. He's not my mentor, he's the mentor of the many mentors in this institution and in this country and abroad as well. And he's the teachers of the teachers of the many students. They are doing a lot of good job in this globe. So, and also I want to thank, before I introducing my sir, that is Professor Jyotirmoy Pal and all the API body, to organize this type of case-based discussion and also the approaches of the different syndromes for the MD students. Because in this COVID scenario and all these things, there is really a problem regarding taking class and all these things, and the syllabus has to be covered. So this is a very good gesture and a good way of actually teaching and modalities. And Professor Vivekananda Jha is a professor and is the executive director of the George Institute for the Global Health India and chair of Global Kidney Health in the Faculty of Medicine, Imperial College London, UK. He is also a conjoint professor of medicine at University of the New South Wales, Sydney, and the immediate past president of the International Society of Nephrology. His research experience and interest include the understanding of the health and the societal impact of non-communicable disease, especially the kidney diseases around the world, through the epidemiology, clinical trials, implementation, science, and the late-stage translational research. Development, affordable, and the scalable and the sustainable primary and the secondary prevention tools. The health policy research that engage with state and the federal health officials in India. As the executive director of the George Institute, he manages a large program of work around the non-communicable diseases. He has worked with the World Health Organization and the kidney disease, improving the global outcome, KDIGO, to develop clinical practice guideline and the advocacy papers. He has been an active investigator and has received the funding from the several organizations as PI and the co-PI, including the UK Medical Research and the Council Australia, and Professor Jha's research program is spread over the several states of India, Thailand, and the Sri Lanka. He has chaired working group that developed guidelines of the National Dialysis Program and the care pathways for the management of the various kidney diseases under the National Health Insurance Scheme. He is also a practicing nephrologist and leads a translational science laboratory at the Postgraduate Institute of Medical Education and Research, PGIME at Chandigarh. He has mentored several early and the mid-career researchers. Professor Jha has published over 280 papers in peer-reviewed journal and 30 chapters in the major textbooks. He has been elected as a fellow of the Royal College of Physicians, London, Royal College of Physicians, Edinburgh, and Medical Science, India. And there are a lot of other feathers in his. I'm not going to all details because he's a doyen of this field, and he's a teachers of the teachers and the mentor of the mentors in our nephrology society. Thank you. Good morning, sir. And we should proceed the actual case-based presentation.
Thank you very much, Professor Mukherjee. And let me also express my thanks to all the colleagues from the ICP West Bengal chapter, especially Professor Jyotirmoy Paul, who invited me to participate in this case-based discussion. And I'm very pleased to see my old friend, Dr. Shivendu Ghosh, also on the call. And I'm sure that there are many other senior physician colleagues from the West Bengal ICP chapter on the call. And please accept my greetings as well as best wishes for the new year that started just yesterday. I'll also like to welcome Kaushik Samanta, who will present the case, and postgraduates who might have joined online as well. One of the things that I like to do the most, as Pinaki and others might attest, is to interact with students, not only because it's an opportunity to teach, but it's also an opportunity to learn. I have learned as much from my students in the past, rather more than I have been able to teach them. So when Dr. Jyotirmoy Paul asked me to take this session, I immediately said yes. So it's my great pleasure to do this, and very happy to start whenever you are ready, Dr. Samanta.
Yes, sir. Thank you so much, sir. Sir, am I audible?
Yes,
yes, audible. Yes, proceed.
Okay, sir. I'm sharing my screen. Sir, is my screen visible?
Yeah.
Okay. Good morning, all my teachers and delegates and my colleagues. Now I am going to present a nephrotic syndrome case-based discussion. I am Kaushik Samanto, third year medicine PGT from Arjikar Medical College. Sir, I am starting.
Please go ahead. Yeah.
Okay, thank you. The patient, 15 years, resident of Barashat, male. The informant also, patient was himself and his mother, who was reliable. And date of admission was 22/12/21 and date of examination 24. Now, chief complaints. The patient presented with puffiness around both his eyes for 3.5 weeks and swelling of both lower limbs and abdomen for last 2 weeks. Now, coming to history of present illness, the patient was on his usual activities 3.5 weeks earlier when he noticed puffiness around both his eyes for the first time, which was insidiously progressed for the next few weeks. The puffiness was noticed by the patient himself more in the morning when he goes to the bathroom and washes his mouth and gaze in the mirror, and the puffiness reduced as the day progresses. The puffiness was progressive and involved whole the face, and he also noticed swelling in both lower limbs, which started in feet and progressed up to knees. After a few days, patient noticed abdominal swelling, which was also insidious in onset and gradually progressive, but not associated with any pain. This was associated with decrease in frequency. According to him, previously it was 9 to 10 times in day, but now 4 to 5 times a day. Mother also told that the urine was frothy in nature. Now coming to important negative history.
Acha,
There is
before the
no-
negative history, actually, Dr. Shivendu Pal is actually want to interpret you. Dr. Shivendu Pal, sir.
Yes.
Shivendu Ghosh, sir. Acha, he's muted. Dr. Shivendu Ghosh, sir, is muted.
Yes. Pinaki,
Yeah,
you
sir.
tell me. Yeah.
Yeah, just ask the question whatever you want to from this.
Can he summarize the case again? Is it possible?
Yes, sir.
Because
Yes, sir.
he's now presenting only the present illness. Now there is a negative history and all these things. Then finally he will summarize.
I think still it's a good idea, as Dr. Shivendu Ghosh says, for the candidate to tell us from the positive history, what did he understand?
Exactly,
I
sir.
think there is someone who wants to ask, whose hand is raised, Shubhanshu Pal. So maybe you want to ask him a question, Pinaki?
Yes, sir. Actually, he's not actually showing in the screen. That is actually,
Right.
I don't want to the who is
I
raising
think
the hand.
it's a good idea for anyone who wants to ask a question to write it in the
Chat box or
right,
Chat box. Yeah.
write in the chat if there is a question, so that Dr. Pinaki can go ahead and ask a question to the candidate. But
or the raise hand. No problem.
Dr. Samanta,
Yes, sir.
please, can you summarize the positive history that you have got from the patient, as Dr. Shivendu Ghosh
Okay, sir.
asked you to do?
Okay, I'm trying. Sir, a patient, male, 15 years patient, presented with puffiness of a face 3.5 weeks earlier, not associated with any other complaint like dyspnea or chest pain.
So you are mostly repeating the symptoms, but now what is expected of you at this stage is for you to now provide your interpretation of the symptoms, summary along with the interpretation. So one of the things, and this approach, if you take in all your cases, it will help you. For example, one of the things that we might want to hear from you: do you think this illness is of acute onset, subacute onset, or is it a chronic disease? That's one. That's one. Secondly, is it progressive? Can you also make some idea about the course of this disease? For example, it could be progressive. It could have started and then now it's decreasing, or it is fluctuating in terms of its severity. That is number two. So I think, those two things will be very important to for you to consider in your summary. And then you go on to describe what does the constellation of symptoms, because right now you have only taken the history, so you only know the symptoms. So what does the constellation of symptoms suggest to you? So if you can summarize in using these principles, I think that will be good.
Okay, sir. Thank you so much, sir. This is subacute in nature. First point. Second, this is progressive over whole of the body. And third is maybe as the patient first presented with edema over eye and face, maybe this is from renal origin, because soft tissue. This patient is child, mainly 15 years. So this is and after that, this patient presented with a bipolar edema, which is mainly gravitational. So maybe this is a renal origin. From history, I can suggest this much, sir.
So it is, thank you. So it is acute to subacute in onset, right? Because when it started suddenly. So that's number one, because it's a 3.5 week old illness, right? By the time the patient presents to you. And the second thing is that it is progressively increasing. It has not yet shown any sign of reduction, right? So that's also important. So it's an acute to subacute in onset, and it is progressive. So far at the time of illness, it is a progressive illness, right? And the second, you said that his the constellation of symptoms that he presented is suggestive of progressive development of anasarca, right? Eventually is what he told you. So you should, while you are right that renal origin can definitely be considered very high on the list, what are the other possible origins that you might consider for someone who presents with anasarca? And you might want to exclude some of them from further questioning or during your physical examination. So what are the other things that come to your mind in addition to renal illness?
Sir, two other system may be involved. First is CVS, cardiac system, or any cause of cardiac origin, and second is hepatic origin. And other, if acutely, this may be systemic illness like so angioedema maybe, but not only acute, this also mainly sir two, like cardiac origin or liver origin, that is abdominal.
Right. Dr. Shibendu Ghosh.
Yeah. I got your ideas and also ideas from Kaushik. Kaushik, it's very, I truly agree with you that renal origin should come first, but there are plenty of causes. But you should exclude this thing. Angioedema should be in the very low in the list. It is producing generalized edema is very, very unlikely to be present. Cardiac origin, particularly some form of cardiomyopathies, can have sometimes with the onset in the eyes first, the edema, I mean the puffiness of the eyes, but most of the time renal origin is important. And for the hepatic, it is very unlikely to involve the eyes first. It is most of the time starts with the abdomen first, and sometimes leg and abdomen simultaneously, or it is abdomen then legs only. The edema are like this.
Yes, sir.
So I agree with all the things you have described about generalized edema. But what's about the malabsorption syndrome? Do you think that patients having malabsorption syndrome presents like this, particularly
Yes, sir.
protein losing
Protein losing,
enteropathy?
yes, sir. Protein losing neuropathy or protein energy malnutrition can present like this.
Protein losing enteropathies. I think 15 years, no. So you can think of a PM, but PM is not applicable at this age, most likely. So I think you should think of first of other thing like protein losing, like the patient is having a problem of malabsorption syndrome, including giardiasis, which may have severe hypoalbuminemia and other related problem. So can you think that also?
Okay. Yes, sir. Sure, sir.
So Dr. Jha, I think these are some of the important point, and he go according to some of the findings of the in signs and symptoms and the history where he can go ahead. Dr.
I
Vivek.
think, yeah, 1 minute. I think the patient have no dyspnea.
No,
No.
sir.
So cardiac edema can be excluded.
Yeah, we
Cardiac edema
have-
without dyspnea is very unlikely.
We haven't yet come to the negative history, Dr. Ganguly. So
Yeah.
right now, you are exactly right that absence of dyspnea is a strong point against a cardiac origin. So Dr. Samanta will perhaps tell us that this patient did not complain of dyspnea, and in which case he will then have that argument that he can use. So go ahead, Dr. Samanta, please describe
Yeah.
the
Yeah.
negative history.
Okay, sir. Thank you, sir. Now coming to negative history, there is no history of shortness of breath or usual activities like playing in field or palpitation or chest pain, sweating, syncope, symptoms, sciatica, orthonia, or PND. There is no history of yellowish discoloration of skin and urine, antecedent or recurrent respiratory infection or skin lesion, no history of cola color urine. Blooding of vision, headache, vomiting is also not there. Pain, abdomen, diarrhea, fever, rashes, joint pain, body ache, passage of red color urine, weight loss, loss of appetite, exposure to toxic drances, all are not present there.
Okay, so can you explain from this list of negative symptoms, what exactly do they tell you in terms of either confirming some diagnosis or excluding other diagnostic?
Mainly, sir, it's excluding other diagnosis. First is that, as sir said, Ganguly sir said, sir, no, there is no history of shortness of breath or usual activities. That is, I am trying to exclude cardiac origin. And sir, yellow discoloration of skin and urine, I am trying to exclude any liver origin or hepatic failure. Antecedent or recurrent respiratory infection or skin lesion, I am trying to exclude in PIGN or PSGN. Blooding of vision, headache, vomiting, there is no systemic illness like hypertension. There is no pain, abdomen, diarrhea, excluding like giardiasis and also hemolytic uremic syndrome and fever. There is no, I like to say fever, any infection, there is many infection which is I go rather after some time, and rashes, joint pain, body ache, which is I have to try some I want to exclude some secondary causes like some autoimmune disorder, passage of red color or cola color urine, same PIGN, weight loss, loss of appetite. I try to exclude some chronic illness or some malabsorption syndrome, or expert to toxin or drug illness, because many drugs or toxin can present it like this. So this is
Right. That's right. So when you said that from history of cola colored urine, you wanted to exclude PSGN, which is absolutely fine. But what are the other types of kidney disease that you can exclude, or you are trying to ascertain
Yes,
whether it is present?
yes, sir. Cola color or red color really means hematuria may be there, and by as there is no hematuria, I can exclude. First is renal vein thrombosis can be excluded, IgA nephropathy can be excluded, PIGN can be excluded, sometimes polycystic kidney disease can be excluded, or any this is 4.
Right. So I think in summary, what you can say is that you want to you are trying to exclude proliferative types of glomerular disease.
Yes,
so, provided that this is kidney disease, which we are not 100% sure yet. So the causes, various types of kidney disease that can give or present with edema like this can be grouped under certain syndromes. So one is a nephrotic syndrome and the second one is a nephritic syndrome, right?
Yes,
Or there can be a mixed presentation,
Mixed
also
syndrome,
combined
nephrotic,
nephritic presentation. So nephrotic syndrome, a typical pure nephrotic syndrome, develops as a result of non-inflammatory glomerular disease, right?
yes,
And in nephritic syndrome or a mixed nephrotic presentation, the glomerular disease that causes is inflammatory type of glomerular disease, in which there are inflammatory cells inside the glomerulus, right? And if there are inflammatory cells inside the glomerulus, typically the patients will develop hematuria, either gross hematuria or microscopic hematuria.
yes, sir.
So what you are trying to think in your own mind is, does this patient have any proliferative glomerular disease or non-proliferative glomerular disease? That's just one thing. So it's broader than, so you don't have to say individually PSGN, IgA nephropathy, and so on, but you capture all types of proliferative glomerular disease.
Yes, sir.
Then I don't know if you are looking at the chat, but there are a few other questions also. Is there any history of easy bruising, stretch mark on the abdomen, or drug abuse, etc.?
No, sir.
Steroid use also.
Yes, sir. There is no drug intake history, or there is no easy bruising, sir.
Right. And I think someone has suggested that myxedema can also be a cause for anasarca, which is absolutely correct. But myxedema is typically a subacute to chronic presentation rather than an acute presentation of 2 to 3 weeks. So that's something which is useful. Now you said that you wanted to exclude secondary causes by looking at the history of fever, rashes, joint pain, body aches. So what are the important secondary causes that present with nephrotic syndrome, secondary kidney diseases?
Yes, sir. Sir, I can classify like infection, autoimmune, toxin, and drugs. In infection, there is some infection typically present in nephrotic syndrome, like hepatitis B or hepatitis C infection, or HIV infection.
Yeah, but hepatitis B, hepatitis C infection will not present with fever, rashes, joint pain, etc., right?
So typical rashes, joint pain.
Yeah, so because what are the causes of kidney disease in which nephrotic syndrome might be associated with some fever, some rashes, some joint pain, etc.?
Sir, SLE, mainly SLE.
SLE, yes, very good. SLE is an important cause. What other causes?
Sir, IBD associated some diseases.
IBD?
Sir, no. So rashes, joint pain, other autoimmune disorder like sir, if sir hepatitis C has cryoglobulinemia, then can be present.
Yes, cryoglobulinemia is one condition. You said SLE very important. SLE is one of the most important secondary causes of nephrotic syndrome. And then you can have in a 15-year-old person condition like inox online purpura.
HSP, yes, sir.
HSP could be one possibility, but in HSP typically you have
RPG,
hematuria as
RPG.
well.
R-
So
RPRS,
RBC, you haven't looked at the urine, you haven't done urine microscopic examination.
no,
So
sir,
there
just
may
I
still
sell
be-
for the urine. Only I sell,
Right.
sir, for the urine.
Yeah, so in the history, you haven't gotten history of any red colored urine. So there is no gross hematuria for sure.
No, sir.
But I think these are the important, then other vasculitic conditions, which can rarely cause pure nephrotic syndrome, but
Yes, sir.
other vasculitic conditions will typically have a mixed nephritic presentation or a rapidly progressive glomerulonephritis.
Glomerulonephritis, yes, sir.
But you are right, is that at least from history you are trying to exclude other causes of anasarca, such as heart failure. And when you say cardiac cause, in cardiac cause, typically anasarca develops in heart failure, not
Heart failure,
other
yes, sir.
types of cardiac
No,
conditions.
sir, yes, sir, heart failure.
Right? And in anasarca of heart failure, patients will generally have dyspnea or
Yes, sir.
paroxysmal nocturnal dyspnea, those sorts of things, orthopnea, PND. And similarly, there is nothing at least active to suggest history of liver disease in this case.
Yes, sir.
Dr. Ghosh, Dr. Pinaki, any questions from you?
Yeah, that is the one that is also came with the chat box. Is there any connective tissue disorder you are thinking in this state? Autoimmune or connective tissue disorder?
No, sir. First is the patient is sex is male, the first point, and 15 years age, only 15 years age, and purely first. No, at this stage, I'm not thinking of any connective tissue disorder.
Because age is not always there, because many patients maybe some MCDD type of pictures, or maybe some connective tissue overlap, cholangitis overlap syndrome maybe there,
Yes.
but though it is unusual. But in these cases, you have to take history or according to investigation to rule out all these things.
Yes, sir. Yes, sir. Sure.
So one point I want to mention over here also, that you must have a history of hematemesis or melena in this patient to exclude if there is any chronic disease from a chronic onset, which has now produced as acute or subacute onset of the disease. That
Yes,
can also mimic this nephrotic syndrome like picture what you are want to impress us. And
Yes, sir.
second thing is that a chronic or even a acute or subacute onset of inflammatory pericardial disease. So that can produce without any dyspnea. Patient can have the anasarca-like presentation, particularly in a subacute form of chronic pericarditis. So that is one of the things you should consider in these patients.
Yes, sir. Yes, sir.
About the history and other things, you should try to rule out that thing. So chronic inflammatory disease of the pericardium, which has not involved the myocardium, can have a no respiratory syndrome anasarca with heart. So, for example, is pericardial failure. That should be considered in this patient as well,
Yes, sir.
along with other causes of vasculitis like your P-ANCA associated or other associated vasculitis, any lung problem, any hemoptysis. That also should be considered in this patient, I think.
Yes, sir. Yes, sir.
Yeah.
Dr. Ghosh,
Yeah.
Dr. Ghosh, I think he can straightly say the constrictive pericarditis. That is a better terminology for these types of
No,
problems.
not chronic, only constrictive pericarditis. It's a constrictive, before constrictive, they have got a one stage of subacute effusive constrictive type.
Constrictive.
Yeah, that is better term as per the history is concerned. That should be maybe considered at least in this case.
Adhesive constrictive.
Yeah.
Okay,
So I
proceed.
think, okay, Vivekananda, please proceed with the and allow Kaushik to proceed maybe.
Yeah, absolutely. Please go ahead.
Okay,
Dr.
sir.
Kaushik.
Thank you, sir.
Yeah.
Now, coming to past history, no similar history like this episode in his childhood, and no history of tuberculosis. Medical history.
Suppose there was a history of tuberculosis, what would that have told you?
Sir, two things. TB itself causes some other disorder extra manifestation and TB drugs. If a patient has TB, maybe TB drug, anti-tubercular drug presented, some anti-tubercular drug can present like nephrotic syndrome presentation. And second is TB itself. If there is any latent TB, we can't prescribe some drugs like steroids. So in this thing mind, I have taken this history.
So TB does not directly lead to nephrotic syndrome, right? And
Yes,
anti-tubercular drugs, to the best of my knowledge, I don't think there is any known anti-tubercular drug that can cause nephrotic syndrome.
So only
Unless,
proteinuria, rifampin can do
The
proteinuria. Rifampicin
AIN.
can,
Mainly cause AIN.
it can
Yeah,
cause
yeah.
interstitial nephritis. So it can cause kidney disease, but not pure nephrotic syndrome like this. I think there is someone, Dr. Debabrata Sarkar is talking about amyloidosis. So that's one very good condition that
Yes,
one should keep in mind.
age is not matter.
Well, if there is active tuberculosis which is not treated, then it can cause amyloidosis at any
Yes,
age because it's secondary cause. Primary amyloidosis is usually is an illness of older individuals,
Yes,
but secondary amyloidosis in someone with untreated tuberculosis can present at any age.
yes, sir.
But please go ahead.
Okay, sir. Medical history: patient is not a known diabetic or hypertension or hypothyroid. Family history: no similar disease in his family member, whether he is antecedent family member. Allergy and treatment history: no known drug or food allergy. No recent vaccination, but according he has completed all the vaccination according to national immunization schedule. After hospitalization, received some injection or oral medicine. Specifically, after doing renal biopsy, we started Visolon. Antenatal history: the patient is a firstborn out of non-consanguineous marriage. No significant history in any trimester, or no congenital infection during birth. And birth history also there is no significant history. Developmental history: all milestones are normal according to his mother. Immunization history: immunized up to date, as I told, in according to NIS. BCG scar present. Optional vaccination not taken.
So BCG scar you should mention in physical examination. It's not part of history anyway,
Yes.
but then it's a minor point.
Sir, this is up to history, and after that examination. So, sir.
Okay, thanks. So in history, I think we have discussed quite a few things already, but is there anything else that you would like to add to your interpretation of this patient's symptoms after the, you've presented the rest of the historical findings?
Yes, sir. I also try to exclude other things like there's no similar history in past. This is important. So some congenital any nephrotic symptom I am trying to exclude. There is no similar history in past or in childhood.
Congenital is very at the age of 15 for someone presenting at the age of 15 years. I don't think you should even consider congenital nephrotic syndrome or mention, but I think it's important for you to say that there was no history of any similar symptoms in the past, because nephrotic syndrome can be remitting and relapsing, especially minimal change disease and other types. So, that's important. And the second very important historical point I would like to really highlight is the family history. And I would, for someone who presents with a nephrotic syndrome at the age of say 15 years, 15 years is a little on the older side. But if he was less than 10 years, for example, I would definitely want to consider very strongly familial or congenital cause of, congenital, I should say, but the genetic cause for his nephrotic syndrome, at least in mind and during the process of workup of this individual. So you said that he was firstborn, but how many other siblings does he have? I think it's important to mention.
Yes, sir, two siblings.
Two siblings, and they're all normal.
All normal.
And both of them are normal, and there is no history of similar illness or any other type of kidney disease in any of the extended family members also.
Yes, sir.
I hope you have ascertained that. That's important, and you should mention it. And you did say that he was born out of a non-consanguineous marriage.
Yes, sir.
Okay. Anything else you want to ask, Dr. Mukherjee, Dr. Ghosh, or any of
Yeah.
the other colleagues?
There's then another issue that you have to ask, at least mention, why this swelling provokes, whether in the previous infection where it was unnoticed, or some some drug has been given for some other reason which was unnoticed. So which is provoked this kind of swelling or the proteinuria?
Yes, sir. Actually, I have tried to some infection, right? There is no antecedent upper respiratory infection or skin infection
Well,
first.
sometimes mild infections is because remain unnoticed, or
Yes, sir,
some
yes, sir.
common medications or some treatment with the local physicians,
Yes,
they
sir.
actually forget to details. But you have to
Yes,
ask,
sir.
is there
Yes,
any
sir.
such incidence is
Yes,
there?
sure, sir.
I think Vivekananda, he's doing well.
Yeah,
He
he's
can
doing.
go ahead.
Carry on. Yeah. Please carry on.
Yes.
There are a
Yes,
few
sir.
questions in the chat, but we will come to those questions a little later on.
Yeah.
Yeah.
Yeah. Do that.
Go ahead, Dr. Kaushik.
Okay, sir. Sure. Thank you. Sir, now coming to examination. General survey. Child is conscious, oriented, obeying commands, right-handed, build is average. There is no signs of macro or micronutrient deficiency. Pallor was present. Icterus cyanosis clubbing absent. Edema, which was bipedal, pitting edema. There is as periorbital puffiness. In oral cavity, there is no finding. Height is 155 centimeter, and all the measurement I have taken. This is a chart which is adaptation from IIP chart, which is mentioned later. 155 centimeter, that is 10 to 25 percentile. Weight is 49 kg, more than 50 percentile. Pulse was 98 millimeter, and also normal. And there is no radiofemoral delay. Peripheral pulse is palpable, but as there is edema, which is present in lower limbs, palpated with difficult. And BPS 134/80 left turn. This is also more than 95 percentile. Respiratory rate 60 per minute. There is no trophic or ulcer and no lymphadenopathy. And I would like to show this is the IP adaptation for IP chart. This is height in or percentile, and also weight is there. And this is blood pressure, which is I attached this, and these two. So this is now general survey.
Okay, so tell us what lessons do you draw from this general survey?
Sir, just this is imposing this all history, that is there is pallor present, maybe due to edema. First point. Second is there is edema, periorbital puffiness is there. The height is little less. This maybe because her mother actually, sir, his father is not come, so I can't calculate mid-parental height, but this is maybe familial. And weight is 49 kg. I asked repeatedly mother, is there is any weight previously, whether she know weight or not, but there is no documentation of weight. So this is more than 50 percentile. And sir, BP is also left arm, because sir, there is channel in cubital, so I take this left arm, and BP is more than 95 percentile, so this is higher. And sir, there is also no trophic ulcer, skin changes, lymphadenopathy. So I am trying to also exclude some secondary causes from this general survey. Sir, this is.
All right, very good. So you are right in your approach. So the blood pressure is a little elevated, right? So what
Yes,
does
sir.
it tell you?
Sir, first is maybe this is due to two cause, whether this is due to sodium or water retention, there's edema maybe there, or this is it tells if I suggest renal causes, this maybe this is some glomerular compartment.
Right. So
Initially.
it could be because of two reasons. You said so salt and water retention. So don't say edema, because edema is extravascular salt and water retention. But if the blood pressure goes up, then it is intravascular.
Intravascular, yes, sir.
Okay, so that can be an important cause of raised blood pressure. And the second also you should, because this is a kidney disease you are thinking of. So whenever the blood pressure goes up, we somewhere in the back of our mind an alarm goes off. Is it chronic kidney disease that we are dealing
Yes,
with, right? So we should always keep that in the back of our mind. Similarly, this child's height, you may look at other members of the family, whether they're short or tall, etc. But otherwise, from the population norms, his child, this 15-year-old boy's height is 10th to 25th percentile, right? So a little less than what you would expect,
Yes, sir. Yes.
right? So once again, growth retardation can be a feature of
Yes.
chronic kidney disease, right?
Yes, sir.
It may be perfectly normal, but it can also be a feature of
There's some
chronic kidney
chronic disease, whether
right?
chronic.
So you should just keep that in mind as possibilities.
Yes, sir.
But other than that, you know, you haven't found anything specific in physical examination general survey that will point you in the direction of any specific cause, right?
Yes, sir.
Sir,
Go ahead.
regarding the general survey, actually, you have to actually mention the parietal edema and the sacral edema. That is also important. Yeah, to at least you have to see at least to all this.
Absolutely, very important. You should mention. So I think this is also important in the type of patient that you are dealing with. And especially when in this patient, when you said that the edema is very obvious, there is periorbital puffiness, there is pedal edema, etc. Let's say if this patient did not have periorbital puffiness and the pedal edema was only mild, where else will you examine in order to elicit edema?
Yes, sir. Because patient is lying down, maybe there is sacral edema also there.
Exactly. So you should look for all of those. All of those things, especially in that type of patient. In a patient who has obvious edema everywhere,
and they also got measurement of the girth.
Yeah, there is no specific reason to mention sacral edema, etc. When there is quite obvious pedal edema, periorbital puffiness. But you should mention then in that case the term anasarca, that in physical examination you find anasarca in this individual. Okay, go ahead.
Sir, this is routinely practiced to measure the abdominal girth.
Yes, sir. Actually,
we haven't come to the abdominal examination, so maybe he will mention it there.
Over there. Okay.
I think there is one question, and we might take that question right now because since the point was raised. What are the differentiating points of acute versus chronic kidney disease? So, Dr. Samanta, can you provide an answer to this question?
Yes, sir. Acute versus chronic kidney disease. First point is in chronic kidney disease there may be anemia. First point.
Again, whenever you ask these kind of questions, divide your answer into history, physical examination, and laboratory findings.
Okay, sir.
So, what do you see in history?
First is history. In in acute kidney disease, as this is acute, there is some typical finding like acutely there is oliguria or anuria. Second is some itself suggests some uremic symptom, whether this is compensated. So there is
uremic symptoms can be present in acute illness also, but yes, I think the duration of symptoms, right? That's important. So if someone has long duration symptoms, then obviously this becomes chronic. But I think this question is relevant only when someone has presented with a relatively short duration history, and you want to try and ascertain if the illness has been there for a long duration and the patient has not come to attention or has kind of ignored some symptoms. So what are the type of symptoms or physical signs that you would want to elicit to differentiate between or to try and play a detective? You have to now be a detective and try to find clues which will tell you whether there is a chronic disease also underlying.
Yes, sir. Some signs typical of like pallor or anemia, which is present.
So again, history. What do you ask in history?
Okay, in history, in acute chronic chronic is symptom of anemia like sir, easy fatigability.
Yeah. So if there is any history of any even vague symptoms, the patient may not attribute too much significance to those symptoms. But if the patient gives any history of vague weakness, general weakness, etc., then that indicates that possibly there is underlying chronic
disease.
Then there might be history of nocturia or polyuria.
Yes,
one of the early features of chronic disease is loss of concentrating ability.
Concentrate.
So the patient becomes patient starts to get up at night to pass urine.
Yes, but this is child mainly 5 years or 6 years nocturia. I can't interpret like sir.
Yeah, so this is a 15-year-old child. So this
Yes,
is
sir,
not a
yes.
5. Yeah. So
Yes.
in a 15-year-old person, if there is history of nocturia for
Nocturia.
2-3 years, then it indicates that possibly the kidney
Chronic
disease
disease.
might have been there from before.
Chronic. Yes, sir. Yes,
All
sir.
right.
Absolutely.
And of course general symptoms, etc. Lack of growth. If the parents
Stunted
are
growth.
able to tell
Yes,
you,
sir.
right? So those may be
Anorexia.
subtle indicators of chronic kidney disease. Then in
Yes, sir.
physical sign, you said anemia. What else?
Physical signs, and the first is anemia. So it's the same stunted growth maybe there.
Yeah, growth retardation. You can confirm if there is growth retardation. If there is hypertension, that may also
Hypertension.
be significant hypertension. That becomes a significant pointer against, or against being just an acute illness.
Yes, sir. Yes, sir.
In history, then you can see if there are any physical examination, if there is any sign of rickets. So
Yes,
there
sir,
could
sir.
be renal rickets that might
yes, sir.
indicate chronic
disease,
kidney
bone
disease,
middle,
chronic disease.
yes, sir.
Right. What else do you see in physical examination to indicate chronic disease? These are the main points. So I think these are the things that you want to see in history and physical examination. Another question that has been asked is differentiation between nephritic and nephritic presentation.
Sir, nephrotic presentation means in nephritic actually the symptoms of symptoms mainly presented like as cholacard urine, as it said. There may be hypertension. There may be some antecedent or precedent some illness, whether in case of sore throat, that is sore throat or impetigo skin infection, or
so the most important feature of nephritic illness is the presence of hematuria. Either gross hematuria or microscopic hematuria, right? So anything that gives you an indication that there might be hematuria, like you said, history of cola-colored urine or red urine, etc., is a feature of indicating nephritic presentation or nephritic syndrome. Similarly, systemic signs are more likely to be associated with nephritic presentation.
Nephritic syndrome, yes, sir.
But other than that, history and physical examination will not allow. And then you may have hypertension more commonly.
Hypertension more common, nephritic, yes, sir.
Right. And then someone says active urinary sediment, which is of course true, but then that you will know only on physical examination. All right, please go ahead.
Okay. Coming to systemic examination, GIT, upper GIT, there no obvious abnormality are there. Per abdomen, examining supine position. On inspection, uniformly distended abdomen, abdominal girth. When just patient came, then it was 84 centimeter. Later, which was increased. Move equally with respiration in all quadrants, that is bilaterally symmetrical. Umbilicus is shifted downwards, that is not in central position, slit-like. There is no stria, flanks are full, hernial orifices are intact, calf influx was negative, and external genitalia, there is no scrotal swelling or cellulitis over the scrotal skin, there is no ulcer.
All right, very good. Did you look for shifting dullness?
Yes, sir. Now, superficial palpation, there is no local rise of temperature, parietal edema present, no tenderness in any quadrant, and deep palpation, there is liver spin not palpable, which was done in deeping method. Now, dull on percussion, yes, sir, there is septic dullness present and also fluid thick present.
All right, very good. And what else should you mention as negative findings here?
First is, sir, abdominal tenderness, which is typical of, because in nephrotic syndrome there may be peritonitis. There is no rebound tenderness is there, specifically rebound tenderness. There is no rebound tenderness is there, and there is over no stria, as I mentioned. There is no bluish over abdomen, and also there is no renal angular tenderness also.
Yeah, renal angle tenderness is not so important, but if you remember, we initially discussed the differential diagnosis of anasarca, and liver disease was considered as one possibility. So since you are examining the abdomen, you should also look for anything, or at least mention that there is no finding which might suggest liver disease. And what kind of findings are you looking for?
Sir, like caput or any sign of portal hypertension, like any splenomegaly. There is
Yeah,
no
so there are no
splenomegaly.
prominent blood vessels over that.
Blood vessels.
You can simply
Yes.
mention that, and there is no splenomegaly, which you already mentioned. There is no splenomegaly. All right. Go
Yes, sir.
ahead.
Okay, sir. Now, auscultation, there is normal bowel sound. There is no renal V or other V in abdomen.
Go ahead.
Okay, sir. Now, coming to respiratory system, inspection, upper respiratory tract, there is no abnormality detected. And palpation, normal trachea position in central. Percussion, sir, only as in mid-axillary, there is liver dullness. So, right-sided mid-axillary resonant up to 6 intercostal, dull from the next tree, there is 7th intercostal space, which is stony. And left-sided, the mid-axillary resonant up to 7th, and then dull from 8 intercostal space. And by auscultation, breath sound, normal physical breath sound all over chest except diminished in this basal area. And any advent, there is no other adventitious sound. And CVS,
Right. So what is your interpretation of the
the
examination
patient,
of
the child,
Yes.
so the child has pleural effusion. This is a child has pleural effusion is there.
Okay. Did you look for shifting dullness even here?
No, sir.
Okay. Doesn't matter, but you might want to just complete the examination by saying that you looked for it and it wasn't present.
So coming to cardiovascular system examination, there is no precordial bulge, palpation, apex normal in position, and also auscultation. There is no added sound, and in CNS examination, no obvious anomaly is there.
Right. Okay. Go ahead.
Okay, sir. Sir, can I go to summary?
Yes.
Sir,
Yes. Any
sir,
neurological examination? Did you?
Sir, yes, sir. Just neurological examination. There is no obvious neurological anomaly. So not there.
and also look for the thyroid. Any
Uh,
thyroid abnormality, thyroid palpable, thyroid
sir,
should be looked for.
Yes, sir. In general survey, sir, I mentioned there is no.
There is
sir,
no thyroid
no.
abnormalities.
Yes, yes.
Yeah.
Right. Did you look into the fundus?
Yeah.
Oh, no, sir. Actually, not.
You should always do that, right? Because
Yes, sir. Yes, sir.
you know, in
Hypertension,
nephrotic
yes.
syndrome or kidney disease, glomerular disease, there can be some secondary causes which may also show abnormalities in fundus examination.
Yeah.
Although
Yes,
the
sir.
kind of conditions you are considering here, they are not likely to cause any of that, but still it is possible, right?
Yes, sir. Sir, with your permission, now coming to summary. 15 years old child born out of non-consanguineous marriage with no significant birth, antenatal, and developmental history. Present with puffiness around his eyes and face for last 3.5 weeks, which was progressive in nature with diurnal variation, progressive to lower limbs. So now this is now coming to anasarca, but not associated with any exertional dyspnea, jaundice, rash, arthritis, fever, pain, or any drugs, or associated, not any drugs, but this all associated with oliguria. This is from history, and on examination, anasarca with mild pleural effusion with no organomegaly, no abdominal tenderness or bruit associated with hypertension.
Yeah. Also ascites, right?
Yes, sir. Anasarca ascites. Yes.
Yeah. Okay, go ahead. So what does it tell you? Go ahead.
Sir, now coming to possibilities.
Yeah.
Sir, as from history and examination, the compartment is renal. First point, this is renal origin. So renal origin in renal compartment, this is maybe glomerular compartment. So renal origin glomerular compartment, and there's as from history there is maybe proteinuria is there. This may be in 15 years old child. There may be some.
Why
nephrotic.
do you say glomerular compartment?
The first is sir, two things, that is though sir, hypertension and proteinuria, if I suggest from history, so maybe.
But you don't know about proteinuria, right? You haven't done any
Yes, sir.
examination.
Yes, sir. Sir.
So what is that's the reason you need to be careful in presenting your clinical diagnosis. what you're doing right now is presenting your diagnosis on clinical grounds. So clinical diagnosis is always syndromic diagnosis.
Yes, sir. Yes,
For
sir.
example, heart failure is a syndrome, right?
Syndrome.
Heart failure can be due to a number of causes. So
Yes, sir.
similarly, what is this renal syndrome that this child has?
Yes, sir. Renal symptom, maybe this is nephrotic syndrome first, nephrotic overlap, or sir, lastly, not such thing, but still nephritic syndrome. Maybe.
Yeah, nephritic syndrome is unlikely. This is not the clinical presentation of a nephritic
Yes, sir.
syndrome.
Yes, sir.
The clinical presentation of a nephritic syndrome is typically with cola-colored urine and some past history of a recent
infection. Yes,
infection of some sort. All right. So this is not a typical nephritic syndrome. What you are describing fits most closely with a nephrotic presentation, right?
Yes,
a nephrotic syndrome-like presentation.
Yes, sir.
And it can be a possible nephritic presentation because you haven't done any urine examination.
Yes,
so you
sir.
can't conclusively rule out
Yes,
the presence of microscopic hematuria, right?
Yes,
So
sir.
nephritic. So then the question is, what are the causes of nephrotic syndrome? So what are the causes? So nephrotic syndrome is typically caused by glomerular disorders, is what you should say, right?
Yes, sir. Yes, sir.
Because and why is nephrotic syndrome caused by glomerular disorders?
Because sir, nephrotic syndrome main pathophysiology, that is sleep diaphragm pathology. In sleep diaphragm pathology.
Well, don't go into pathology right now.
Sir.
So one of the what is the cardinal feature of nephrotic syndrome? What is the cardinal feature, clinical examination wise feature?
Sir, periorbital anasarca, first point.
So the cardinal feature is massive proteinuria.
Massive proteinuria, yes.
And everything results from massive proteinuria. So
yes, sir.
not just proteinuria, but massive proteinuria.
Massive proteinuria.
That's important. And so massive proteinuria develops only as a result of nephrotic, I shouldn't say only, but most commonly as a result of nephrotic syndrome.
Yes, sir.
Okay. So let me then stop here and ask you the question, what are the different types of proteinuria?
Sir, like selective proteinuria, orthostatic proteinuria, overflow proteinuria.
So you're mixing up various ways of classifying proteinuria. So you should start by saying that proteinuria can be classified in a number of ways. All right.
Okay, sir.
So one is according to posture. Is it an orthostatic proteinuria, or is it, what is the opposite of orthostatic?
Sir, classical proteinuria.
Or is it a non-orthostatic proteinuria? All right. So it's a what is orthostatic proteinuria?
So orthostatic proteinuria means if a patient stand and working in the day anytime, then due to his
so orthostatic proteinuria is proteinuria that develops only during erect posture.
Erect posture, yes, sir.
And when the patient is recumbent, there is no proteinuria.
No proteinuria.
How do you differentiate orthostatic from non-orthostatic proteinuria?
Sir, if actually I ask patient to when he goes to sleep at night, he micturate. Then after sleeping, when he just got up from the morning.
Right. So you may want to differentiate or look for urine protein separately in urine sample collected while the patient was sleeping or recumbent versus while the patient was erect and going about his or her normal activities. That's one.
Sir.
So one is according to posture. Second is according to
sir characteristic like selective or non-selective.
Correct. The correct selectivity of proteinuria, selective, non-selective proteinuria, and I think you can read about how to differentiate selective and non-selective proteinuria from your textbook. All right. Then what is the third way of classifying proteinuria?
So nephrotic, nephritic range.
Nephrotic or non-nephrotic?
Non-nephrotic.
Right?
Yes, sir.
So what is nephrotic proteinuria?
So to his 3.5 gram per day, and or protein creatine ratio 2.2, or sir 50 milligram per meter square in case of per day in case of children.
Right. So 3.5 grams per 1.73 meters square body surface area per day. That's the classical definition of nephrotic range proteinuria, right? Yes. And right, so that's one other way of classifying proteinuria. What is any other way of classifying proteinuria?
Yes, sir. That is compartment wise, like tubular proteinuria.
Right.
or
Go ahead. Go ahead.
glomerular proteinuria. No, nephrotic also.
No, no. Tubular, glomerular, and
Sir, non.
so here comes your overflow proteinuria.
Overflow
right?
protein. Yes, sir. Overflow.
Because proteinuria can be as a result of kidney disease. All right.
Yes, sir.
Glomerular disease or tubular disease, or proteinuria can be
Other disease. Bone.
present when kidneys are completely normal.
Normal. Yes. Production is high. Overflow. This
Then-
production is high.
Right. So that is overflow proteinuria. So what is overflow proteinuria?
Mainly, sir, in case of when kidney is normally, sir, there is threshold of protein. Our body produce a different level of protein, but if protein production is high from any cause like multiple myeloma or any gammopathy, that is kidney excreted more protein due to increased production. This is overflow proteinuria.
Yeah. So it is when the kidney's filtration function is totally intact. All
Yes,
right. So proteinuria is determined. Kidney disease. How does kidney disease produce proteinuria? It can either filter excess protein, which happens in glomerular disease, or that it may fail to reabsorb proteins. Right.
Yes,
Even when the filtration is normal, normally when your and my kidneys, when there is filtration, there is some amount of protein that comes out in the filtrate, right? But they are reabsorbed in the tubular compartment. When the reabsorption function is affected, such as during tubular interstitial disorders, there can be tubular proteinuria, right?
Yes, sir.
And the third is, as we just discussed, when the kidneys are completely normal, but there is overproduction because of some other reason, and overproduction of protein in an amount which can be filtered by the kidneys, all right? So if there is overproduction of protein which is too large, then you don't get any proteinuria. But if the overproduction is of a size of protein which can be filtered by the kidneys, then you can get overflow proteinuria, such as light chains in the case of multiple myeloma and so on.
Yes.
That is the most common type of proteinuria. So these are the different ways of classifying proteinuria. It's very important for you to remember this.
Sure. Yes.
All right, please go ahead with your differential diagnosis.
Sir,
So there is an interesting question. Someone has asked, Dr. Shubhajit Paul has asked, I think, is it possible to note clinical signs of dyslipidemia and nephrotic syndrome? So what do you say, Dr. Samanta?
Yes, sir. If there is hypertriglyceride, there may be some sign like first is there may be patient presented with abdominal pain, which is a pancreatitis. First point. So second is there is some maybe eruptive xanthoma or xanthelasma. This is key finding. Sir,
sorry, I was muted. Do you get xanthomas or xanthelasma in nephrotic syndrome?
No, sir, not regularly, because this may be hyperlipidemia, familial hyperlipidemia syndrome. This is common, but if triglyceride is so high, then
it's extremely unlikely that you will get these findings in a patient of nephrotic syndrome, because the history is so short.
So short. Yes.
It takes time for xanthelasma to develop. It won't happen in acute illness. So what is, so now here comes, I think this is something which we should have asked you earlier. What is one clinical finding that you can actually elicit in a patient with nephrotic syndrome, which tells you that there is hyperlipidemia?
The urine lipiduria, maybe.
But that's not clinical finding, right?
Oh, okay.
Any abnormality and any abnormality on fundus examination?
Oh yes, sir. So yes, sir. Retina, there is lipid spot.
So there is something called lipemia retinalis. Have you heard of this condition?
No, sir.
So it's So when there is massive hyperlipidemia, especially hypertriglyceridemia, you can see lipid, lipid floating in capillaries, because that is what happens. And the only place you and I can see human capillaries is in the fundus, right? So you can see that in the retina floating. There are it becomes white. The capillaries become white, which indicates the presence of lipids. So that is called lipemia retinalis.
Okay, sir.
All right. So very important.
Okay, thank you.
So go ahead. Sorry, you were describing the differential diagnosis when we interrupted.
Sir, differential diagnosis. So this is from history, and this is nephrotic syndrome or nephrotic mixed syndrome, and those are not other things come not in mind.
Dr. Pinaki, Dr.
Yeah,
Shubhendu,
as it is
you
a
want
say,
to
as
ask
it is a
anything?
as it is a polycystic, even in the patient is elderly, age is 15. So even if you don't know whether it is a primary nephrotic or the secondary, so you cannot rule out the secondary cause of the nephrotic syndrome, right? At
Yes,
this
sir.
stage,
Yes,
at least.
yes, sir.
So even this presentation can be an SLE.
SLE, yes, sir. SLE
Yeah.
can present.
So as it is a polycystic, because proliferation is there, ascites is there, general lesion is there, patient having a
The kidney involvement.
puffiness of face, and presentation is because SLE may present in this
SLE.
way also.
Yes,
Though it is
sir.
a rare because male patient, 15
Male
years,
patient.
definitely.
Yes, sir.
Another thing I'm thinking, Vivekananda, Pinaki and Vivekananda, whether the proliferation is related to something else. Or, well, it can be established that hypoproteinemia related to nephrotic can produce some form of proliferation.
Yes, sir.
Other
Other
than
cause.
of polycerasitis, you think some infection, including
Yes, sir.
tuberculosis,
Yes, sir. Yes, sir.
to
Absolutely.
rule out in this patient, though history is too short,
Yes, sir.
3 weeks only. But even that patient may have an exacerbation of the tuberculosis and
Serotype.
can have a proliferation. We have seen lots of patients having secondary infection in nephrotic syndrome.
Yes,
So
sir.
that
Yes.
is
There
one
is
of
a
the issues I should. Yeah.
Also,
sir,
pneumonia
there is a
proliferation.
tense ascites. Patient is
Yeah.
having a fluid thrill, and
Yes,
the
Yeah.
ascites is present in the right side. So probably it is a hydrothorax, some pro-peritoneal communication may be there, and
yes, sir.
in the background of there is some hypoalbuminemia may be there.
Yes.
So
Yes. Yes.
that is the much because as
Yes,
it is
yes.
this
Pinaki accepted everything, but this
yeah.
is one of another possibility. I'm not
Yeah.
talking, it is same. I'm talking with you, and I do agree that first possibility is the hydrothorax, second
Yeah.
possibility is the pleural communication from the tense ascites, third is some type of infection, maybe underlying lung parenchyma also affected, you do
But
not know.
patient having no
Yeah.
fever, no other any with a short duration,
Nephrotic, not really, but not nephrotic syndrome can have
no pain
febrile
abdomen.
because of the low immunological status. Febrile status may happen, so it is not uncommon to have febrile infection, including tuberculosis in a nephrotic. But only thing is that history is too short. That is one of the very big issues in this patient.
Now we will have to investigate proliferation is transmitted or exuded.
That is very important. Agree.
Otherwise, all are guess. I think
Yeah.
carry on.
Okay,
Yeah.
sir.
Yeah,
And-
Vivekananda, best. Go ahead.
Sure. So I think as Dr. Ganguly says, and whenever we are discussing a clinical case, we should always remember to try and explain every finding with one possible diagnosis.
Yeah.
And the diagnosis of nephrotic syndrome does seem to explain all the symptoms and signs of this patient at this particular point of time. You are right that there can be other very rare possibilities, but I don't think that we would consider them very strongly at this particular point.
Yeah.
All right, very good. So let me ask you this question, Dr. Samanta. So this patient's primary presentation was with anasarca, right?
Yes, sir.
Why do patients with nephrotic syndrome develop edema or anasarca?
Sir, actually, there is two school of thought. First is underfill theory. Second is overfill theory. And sir, in overfill theory, there is in intervascular volume is higher. In underfill theory, intervascular volume is less. As there is nephrotic syndrome, there is loss of sodium or water. There is RAS activation, and after the RAS activation, there is increasing sodium and water retention. And second is there is
So explain. Can you explain again why there is renin angiotensin system activation?
Yes, sir. First is there is there is loss of protein. There is loss of protein in loss of protein. So sir, there is due to loss of protein, there is hypoalbuminemia. So in case of hypoalbuminemia, there is heart space loss. There is colloid tension is poor, less in intervascular system. So there is a third space loss is first point, and renal perfusion is low. So there is intrarenal interglomerular anemia, and this causes RAS activation, as there is due to RAS activation there is sodium and water retention is more.
Okay. All right. So that's your underfill theory. What is the overfill theory?
Overfill theory is due to oh yes sir, if there is oliguria or there is urine card intravascular volume is high in case of I just forgot maybe.
Right. So underfill theory suggests that edema develops primarily because protein is lost in the urine, and because of protein loss in the urine, there is Starling's forces come into play, and Starling forces produce intravascular volume depletion, which leads to activation of renin-angiotensin system, as you correctly predicted. Now, the overfill theory suggests that the abnormality is primarily in the kidneys itself.
Yes,
that kidneys overabsorb sodium, right? Because of some abnormality, which leads to increase in the intravascular volume, right? And that might be what is leading to primary sodium retention. And if there is retention of sodium, it pulls water along with it. And when sodium and water gets pulled, it produces hypertension, it produces
yes.
And the cause for the primary sodium retention by the kidneys is not very clear. But then there are a number of hypotheses, which include overactivation of the epithelial sodium channels in the collecting duct, and that there is some protein loss which leads to reduction in degradation of the epithelial sodium channel, etc. So which means that these sodium channels are able to pull more sodium from the filtrate which comes into the tubule into the bloodstream, right? So there are these two main types of hypotheses.
Yes,
I think it's enough for you to remember these two hypotheses at this stage. All right. So yeah, please go ahead. So let's assume that this patient has nephrotic syndrome. How will you confirm this diagnosis?
Yes, sir. So, sir, I just this is my provisional diagnosis. This is a primary nephrotic syndrome with significant lesion, not associated with other complications. So, as there is hypertension, I initially mentioned this as significant lesion, and after investigation, maybe I coming to more accurately. So, sir, investigation is here. As urine routine examination is very important. So, this is sir, dipstick test, which is suggest protein plus 4+. There is no sugar. WBC 6 to 8 per hyperfilled. RBC also there's 0 to 5. Epithelial cell 1.2. There is serum albumin 2.9, and it's a total cholesterol 400. This is in blood investigation also attached. So now coming to CBC. CBC
so
is
let's just stop here. So what do these investigations tell you?
So first is protein is 4+, but first thing is in dipstick test we can test only albumin, not other protein. So maybe this is albumin 4+, first one, and there is no sugar. WBC 6 to 8, but sir, patient gave in not any history of burning, micturition or signs of UTI. So I can after culture sensitivity there is no also UTI, but still I can overlook this. And also RBC 0 to 5, but there is no presentation of hematuria. And also there is some rule, sir, there is no dysmorphic RBC or sir acanthocyte or any RBC cast. So maybe this is not glomerular origin, and serum albumin is low. So maybe this is some protein losing nephropathy.
Right. So one thing you can say in simple terms, that this set of investigations that you have presented here confirms your diagnosis of nephrotic syndrome.
Yes, sir. Yes,
because there is quite significant proteinuria. It is 4+. You haven't shown me the 24-hour urine protein finding, but let's assume that whatever it is 4+, and it is associated with low serum albumin and high total cholesterol.
Yes, sir.
So, and this patient had a clinical finding of edema or anasarca.
Yes, sir.
These are all the features that are required to make a clinical diagnosis of nephrotic syndrome, right?
Yes, sir.
So there are two things. One is a nephrotic range proteinuria, and second is nephrotic syndrome.
Syndrome. Yes, sir.
So sometimes you may have nephrotic range proteinuria in absence of nephrotic syndrome. So that's also very important to remember.
Yes,
And we can come to the significance of that a little later, but I just want to leave you with this thought that there can be significant proteinuria, but there may not be other features of nephrotic syndrome as
Yes,
was
sir.
present in this case. And you're right that the urine, so this is a dipstick test. So
Yes, sir.
dipstick detects what type of protein?
Only, sir, albumin.
So it primarily detects albumin. You can't say that it mainly detects albumin. And why is that the case? What is the principle of dipstick test?
Sir, color changes in the reagent. There is reagent, the color change, and sir, sir, actually, sir, actually in urine, or there is a strip which is put in the urine, and there is color change.
Yeah, so you said it primarily detects albumin.
Albumin,
So
yes.
I think it's a good idea for you to understand the principle of dipstick testing, right? So it is a color change, as you correctly said. So it obviously contains some chemical, right?
Chemical, yes, sir.
Which reacts with
Albumin reacts with albumin, mainly albumin.
reacts with mainly albumin. And what is the characteristic for albumin?
Negative charge
It's
protein.
a negatively charged protein.
Negatively charged protein.
So it primarily reacts with a negatively charged protein, and the most common negatively charged protein present in the urine is albumin.
Albumin.
Okay, so that is
Okay.
why it primarily detects albumin. That's
Detects
something for you to know. And why it is important is that if there are other types of proteinuria, for example, overfill proteinuria that you said,
Yes, sir.
light
Yes,
chain, in which case, even though there is massive proteinuria, the dipstick test
we
might
can't
be
detect.
negative or only trace positive, something like
positive.
that. That's important. In which
Yes,
case
sir.
you will need to do other. So what are the other ways of testing? Do you ever do or look for protein in the urine in your side lab in your medical college?
Yeah.
Sir, dipstick test.
Do you do any other test in the side lab in your ward, medical ward? Do you have a side lab? Pinaki, I don't know.
Yeah.
Is there any side lab in medical wards these days, Dr.
Yeah,
Ghosh, Dr. Pinaki?
Sometimes we have, sometimes we have to heat test also, and
Yes, sir.
we
Heat
also
Vacuum.
do the albumimeter, but in the central lab, not in the ward.
So that was a very important issue earlier years, Dr. Vivekananda.
HPLC lab. Yeah.
So Vivekananda, yesterday years, we used to do that, Benedict's and albumin and the bedside also. Even we do not have any small lab attached to wards. So, but nowadays it is probably labs are controlling our investigating procedures. So we are morely dependent on the laboratories rather than and dipstick sometimes. As there is protein is very high, sometimes you do heat test and ask the patient relation to do the heat test for to see the importance of follow-up by doing the heat test or even dipstick test.
So I think you should still know all the other types or other methods by which you can detect protein in the urine. So heat test, sulfosalicylic acid test, etc. You should always know the principles of these tests. All right. But dipstick test, it's very important to remember that you may miss certain types of protein if you use only dipstick test.
Yes, sir. Yes, sir.
Right. And RBCs, you have said 0 to 5. What is the normal number of red cells in the urine?
Sir, less than 10.
Less than 10.
No, sir. No, sir. Actually, RBC, there's no RBC cell, 0. it's male patient. So
Yeah, so ideally,
one RBC
normally
is abnormal. We can
you would not expect to see any red
any
cells
RBC, any
in
RBC. One RBC is
in
abnormal.
the urine,
Yes,
but
sir.
sometimes you do see red cells. And in females, what is the upper limit in females?
Sir,
Up to
no,
3. You can see up to 3, per high power field.
yes, sir.
It should still not be more than 3. So anything more, in this case, it is 0 to 5. So it makes me wonder whether, there is some microscopic hematuria going on in this 15-year-old.
Some UTI maybe can cause this.
Can cause, but and the one thing which is not mentioned here is very important, because you haven't mentioned anything about casts, right? So that means that the actual urine microscopy has not been done in this case. It's very important to do urine microscopy in all patients with renal illness or
Yes,
nephrotic
sir, yes,
syndrome, or where you are suspecting primary glomerular disease.
Yes, sir.
So have you ever done a urine microscopy yourself? Or is it
No, sir, but I know how to proceed. But I myself did not do any this.
how do you do urine microscopy? Can you tell
Sir,
me?
actually, in clean catch in morning sample in one test tube, and this is up to sometime 3000 RPM or to 2.5K RPM is a centrifuge. After centrifuge, the last drop in slide, that is the other discard the above all the urine. Just last drop is take in this slide. And this slide is see under microscope whether there is pus cell or cast. This is done.
Why do you centrifuge at 2000, 2500?
Sir, actually, minutes or if 10 minutes I can 3000, but 10 minutes then we can say 2.5 K. But if 5 minutes, then 3000, like this, sir. I'm not sure, sir.
Well, it's important for you to know. You're right that you centrifuge at 2000 RPM per minute, and you centrifuge for almost 10 minutes.
10 minutes, yes.
You don't centrifuge at a faster rate, because if you spin
Disintegrate.
urine,
Disintegrate the RBCs.
not RBCs, but casts.
Cast, yes.
Casts are formed elements. So in urine, you look for protein, you look for sugar typically, and you look for cells, and then you look for formed elements. And formed elements are these casts, which are very important in the differential diagnosis of glomerular disorders, primary or secondary. And in patients with nephrotic syndrome, what are the different types of casts that you can see?
First is nephrotic syndrome.
Yes.
Nephrotic syndrome, different casts. Active sediments like WBC cast can be seen.
What are the different types of casts? Forget about
hyaline cast, granular cast, WBC cast, RBC cast.
And in nephrotic syndrome, now let's come back to it.
Nephrotic lipids, lipid cast.
Lipid cast. Someone says lipid cast.
Fatty cast.
Right. So you can see all of these types of casts in different glomerular diseases, right? Hyaline casts, when the cast doesn't have anything stuck to it, when it's only protein, Tam-Harsfall protein, along with some other filtered proteins.
Yes.
And granular casts is when there are proteins and there are cell debris, which just gets converted into granules. And then, of course, you have the RBC cast and the WBC cast.
The other is muddy cast, waxy cast. Sir, I forgot just.
Yeah. So when do you see muddy casts?
Sir, muddy cast means epithelial. This is mainly CKD.
Not CKD, but mostly
tubular intestinal, any tubular intestinal.
Acute tubular necrosis.
Tubular intestinal.
That's where you see brown muddy casts.
Brown muddy casts.
And what is you said what broadcast? Did you say broadcast?
No, sir. Broadcast is
What is broadcast?
Broadcast means sir, mainly epithelial debris.
Broadcasts are, what the name says, they're wider than normal, casts, and it indicates that there is tubular dilatation. These casts have been formed in tubules which are dilated, And tubular
sir.
dilatation happens when there is
Yes,
chronic
sir.
disease, right?
Yes, sir.
Chronic
Will
disease,
happen.
chronic
Yes,
kidney
sir.
disease.
Yes, sir.
So broadcast is an indicator of chronicity of illness, right? Whatever condition which gives rise to chronic illness will
Chronic
produce broadcasts.
broadcast.
And what is one abnormality which will allow you to make a diagnosis of acute post-infectious or proliferative glomerular disease?
Sir, RBC cast.
RBC casts, exactly. So you should specifically look for RBC casts, especially in patients who are presenting to you with a short history of coagulated urine or red urine, etc. Right. So that's all that is important for you at this point. All right. Any other question, Pinaki or Shivendu, before we proceed?
In a
In this
significant,
case, we need P24 urine protein because that is very important, because that also give you idea the which type of nephrotic syndrome. That is also important. Quantification should be there.
yes, I agree. And echoing the Pinaki's idea that non-nephrotic proteinuria and nephrotic proteinuria, the disease may be to some extent different. Some of the diseases presenting as nephrotic. Yeah.
Maybe he will present later on. So
Yeah,
serum albumin. So serum albumin also you should know that serum
Yeah.
albumin most commonly is measured in the laboratory by chemical methods, right?
Yeah.
So there are two chemicals that can be measured. You can have brom cresol green and brom cresol purple. So there are two, and you will get different serum albumin results depending on what test you have used. So if you use BCG, which is brom cresol green, it will give you a higher serum albumin value. So it's always a good idea to find out which method does your lab use, because the definition of hypoalbuminemia might change depending on the method that you have used. The definition doesn't change, the definition might change, whether it is your serum albumin level is below your threshold of 3.5 or not. If BCG is used, then BCG will typically overestimate serum albumin level, so you'll get higher values. So that's an important consideration for you to remember.
Now, one question. I want
Another
to
issue
ask
is
the
that-
presenter why
Sir.
cholesterol is increased in nephrotic syndrome.
This is an important question.
Go ahead, Kaushik.
Yes, sir. Total cholesterol increase, sir. There is some enzyme dysregulation first, and also there is as there is blunted hepatic response of production of formation of protein like albumin. There is increased production of other protein.
Like?
This first, sir.
Which protein contains lipid?
Sir, there is protein.
It is not a very uncommon question asked in
Yes,
the post-graduation very frequently.
Sir, lipoproteins like lipoproteins.
Like which lipoprotein contains the maximum amount of triglyceride?
Triglyceride maximum.
Why liver produce this
Actually,
to maintain osmolarity?
osmolarity. Yes, sir. Sir, triglyceride increase due to lipoprotein lipase deficiency, but there is VLDL, LDL, all production has increased, sir. Actually, VLDL, LDL, all production is increased. On sir,
I think, Dr. Samanta, this is a very important question, which you will certainly be asked if you get a patient with nephrotic syndrome. So please do make sure that you know the answer, thoroughly. That's very important.
Sir,
Sir,
increased chylomicrons also.
Yeah, that's all right. You can go and read. Right now, I think it's clear that you are not fully
Prepared
convinced.
to answer the question. Okay, carry on.
Please carry on.
Sir, we are actually running late, so you should carry on.
Let's carry on. Let's carry
Okay,
on.
sir.
We should finish.
Now, in CBC, there's hemoglobin 12, PCV 39, TLC little raised 13K, neutrophil 78, platelet 5 lakhs, urea 60, creatine 1.1, sodium 130, potassium 4.5.
So urea 60 and creatinine 1.1, what does it tell you?
Sir, maybe this in case of nephrotic symptom, there is some cause of AKI, and in maybe there is overgelastic use of diuretics, which maybe patient get in outside. First point, there is some dehydration is there maybe, or
There is some degree of there is
Pre-renal
possibly
AKI.
some degree of pre-renal azotemia in this
Yes,
case.
sir. Yes,
All right. So that's all. Which may be present in patients with nephrotic syndrome, even otherwise, because you described the underfill hypothesis. These
Yes, sir.
patients are
Yes,
volume depleted, so the
renal
kidneys are
ischemia.
trying
Yes.
to preserve. Yeah.
Okay. Now to come into 24-hour urinary protein, which is 4.47 gram, volume was 1 liter, and CRP is little dazed, procalcitonin normal, LDH is little dazed. And sir, here mainly finding is C3C4 was normal, ferritin 140, ASO normal, and sir, actually lipid profile is sir also cholesterol 40, triglyceride 440, HDL 25, LDL 170. Sir, all triple serology like HbSAg, anti-HCV, and HIV test was negative.
So let's forget about the investigations here. It doesn't matter really. We have confirmed the diagnosis of nephrotic syndrome. You have shown that the kidney function is serum creatinine is 1.1, etc. So so if you can stop sharing it, it doesn't matter. I want to ask you, how will you investigate? You seem to have done a whole range of, I don't know why procalcitonin and CRP, etc. was done in this child.
Sir, actually, he has deported, but no, we don't not done. He actually he has earlier deported from outside, so just I attached, nothing else.
Okay, so it was done already. But how will you investigate this child now? 15-year-old child presents to you with nephrotic syndrome. What will you do?
Okay, sir. Now, sir, the consensus is actually saying this is 15 years, and in case of typical 15 years.
We are running short of time, so let me just go to the general principles.
Okay,
general principles of investigation, working up any patient. What are the general principles? Why do you want to investigate anyone, whatever be the illness?
Sir, if a diagnosis may make diagnosis.
One is that you want to confirm the diagnosis.
Confirm diagnosis, yes, sir.
Okay, what is the second reason for investigating?
Sir, because whether we continue steroid or treatment.
No, forget about nephrotic syndrome. I'm asking you general principles. Whatever is the health condition, whether it is kidney, heart,
yes,
neurological condition,
sir,
why do you investigate?
Yes, sir. Because if diagnosis, there's to make a good diagnosis, or there is no diagnosis dilemma, then we can apply good treatment strategy or treatment protocol.
So one is that you want to establish the diagnosis. Second, you want to decide the course of treatment.
Prognosis, course of treatment.
What is the third reason?
Diagnosis.
Third reason is you want to find out if there is any associated condition.
Yes, sir. Absolutely.
Right? Associated condition, which may not be etiologically responsible, but if it may be present. Right?
Yes, sir. Yes, sir. Yes.
Because associated condition might also have an influence on your future course of action,
yes, sir,
including treatment.
Yes, sir.
The fourth reason is to understand if there are any complications of the cause that you have found, right?
Yes, sir.
For example, nephrotic syndrome can cause some complications.
Yes, sir.
Right? And we'll come to that in a moment. What is the fifth reason for investigation? You want to understand the prognosis.
Prognosis. Yes.
What will happen to this patient? So these are 4 or 5 reasons for which you do investigation or you work up any patient.
Yes, sir.
So do keep all of these in mind while you are asking for investigations. So anything that do not give you information directly related to these 5 aims, you should not ask for those investigations. For example, doing CRP is totally irrelevant in this child because it doesn't give you any information which helps you with these 5 questions. All right. So, but let me come back to one of these questions, complications. What are the common complications of nephrotic syndrome?
So complication first is thrombosis, whether anywhere, like any venous, mainly venous thrombosis, not arterial, like
venous or arterial. Okay, thrombotic complications.
Thrombotic complication.
One.
Second is itself AKI may happen in
yes, acute kidney injury.
Second is nephrotic syndrome.
You did mention in your history, right? You said there
Yes,
is no
sir.
abdominal pain, there is no
Yes,
tension.
sir. Spontaneous bacterial peritonitis.
Yeah, infections and
Infections.
all kinds of
All kinds
infections.
of gram-negative, mainly gram-negative infections.
Well, not necessarily gram-negative. What are the infections which? What are the types of infections that you see more frequently in?
Mainly, sir,
patients with
Diplococcus
nephrotic?
pneumonia infection,
So, infection with encapsulated organisms.
encapsulated organism.
So those are the ones: Haemophilus influenzae, pneumococcal
Influenzae,
pneumonia. These are the ones that
yes.
you see more commonly, but other infections can also develop.
Yes,
So
varicella.
infectious complications, and especially subacute bacterial, spontaneous
Spontaneous.
bacterial peritonitis is mentioned here.
Yes,
Other
sir.
complications?
Say mesenteric ischemia.
Mesenteric ischemia.
Due to
Why did you
hypovolemia.
specifically mention it?
Sure.
Hypovolemia. Sir, due to hypovolemia, then this can happen. And other is
Mesenteric ischemia only due to hypovolemia? No, no, no.
no.
If there is it can develop as a part of generalized thrombotic hypercoagulability, and you can see the effect of hypercoagulability in many organs, including CNS, including the respiratory tract, deep venous thrombosis of legs, and so on and so forth. So all of those can happen.
And other infection, other complication
Let's
like
say if the nephrotic syndrome continues to persist in
I
someone.
say yes, it's a CI mainly CKD, main last one is CKD, ESRD can happen.
Even before ESRD, what else can happen?
Then before ESRD. Oh yes, sir.
If there is one of the, you said
Hypertension.
hyperlipidemia is one
Hyper-
complication. Say
Complication.
hyperlipidemia will persist. What will it cause?
Pancreatitis.
Not so much pancreatitis, but it can accelerate cardiovascular disease.
Cardiovascular, ASCD, cardiovascular disease.
There is increased cardiovascular disease, both atherosclerotic and non-atherosclerotic,
Non-atherosclerotic.
right? Then it can also lead to bone and
Bone marrow
disorders.
disorder, anemia, bone marrow disorder.
Anemia, bone and mineral disorders, etc. So these are all possible complications of nephrotic syndrome that you should remember. All right. Hypertension is a common complication of nephrotic syndrome. So all of these things can happen. So you should look for. So one of the purposes of investigating a patient with nephrotic syndrome is to look for any of these, whether any or more than one of these complications are present. All right.
Yes, sir.
So, okay, so go ahead and tell me how will you investigate with these principles in the back of your mind, how will you investigate this child?
Okay, sir. First is if I suspect nephrotic syndrome, so diagnosis.
So now we are on this child. You have this child. You know this child's history. You know this clinical presentation. You know the investigation so far. What is the next thing you will do?
Sir, actually 15 years. So definitely I do renal biopsy.
You will do a renal biopsy.
Yes,
okay.
Sir.
Why are you saying this?
Because sir, to predict definitely future outcome.
So the relevant question is, what do you think is the cause of this child's nephrotic syndrome?
Yes, sir. As 15 years says, maybe though MCD is 2 to 12 years, but still this may be MCD, minimal changes. And second is maybe this is FSGS as presented in ES. So FSGS can be there. And as there is no secondary causes, I have not seen no secondary causes, there may be primary nephrotic syndrome due to MCD or FSGS.
Okay, you are right. MCD, FSGS. What would have given you more reason to suspect FSGS?
Hypertension.
There is some degree of hypertension, right?
Yes, sir. And age are important because less than 10 years mainly MCD epidemiologically we have seen in less than 10 years. So
So less than 10 years, you're right that minimal change disease is overwhelmingly the most important cause of nephrotic syndrome.
yes, sir.
But even at the age of 15, minimal change is still the commonest
Yes,
cause
sir.
of
Yes, sir. Yes, sir. Yes, sir. Yes, sir.
FSGS. So if you see any atypical feature, like especially microscopic hematuria,
Yes, sir.
if there is, so that is why you said 0 to 5 RBCs, you know,
Yes, sir.
that kind of raises my suspicion.
Yes,
right?
sir.
That whether there is any FSGS there or not. So any
Yes, sir.
microscopic hematuria, any reduction in glomerular filtration rate,
Yes, sir.
which means raised serum creatinine, but in
Yes,
this
sir.
case, raised serum creatinine can also be because of hypovolemic state.
Hypovolemia,
All right.
diabetes.
So,
Yes, sir.
but what, let's say the child says, or the child's parent says that we don't want to do a kidney biopsy, or we don't want kidney biopsy, then what will you do?
Sir, I straightforward started steroid for at least 6 weeks, and I will say whether responsive or not. Steroid, if there is responsive, then
Right. So
well,
there is an alternate course of action here. One is, of course, doing a kidney biopsy.
yes,
But
sir.
then there is an alternate course of action, which is by going ahead and treating this child with steroids.
Yes, therapeutic diagnosis means.
Yeah. And that will also be an equally valid approach in this
Yes, sir.
15-year-old child who presents with the profile that you have described in
Yes,
the last 2 hours or so. All right. So that could be the other approach in this. But of course, you want to go ahead with kidney biopsy. There is nothing wrong with that. That's a perfectly appropriate approach. All right.
Sir, actually, yes, sir, I have done, and sir, in actually there is nothing in kidney biopsy report because maybe there is whether minimal change or sir unsampled. They said is like this.
So, well, you right now you are medicine postgraduate, so it's all right. It's appropriate for you to just look at the diagnosis. But if you were a nephrology DM candidate or DNB candidate, I would insist that you read the entire biopsy report and then you make up your mind. Don't give me your diagnosis only by looking at the final sentence, right?
Yes, sir.
So why is it called minimal change disease?
Because sir, minimal change means actually this is like a podocytopathy. Only podocytes change. There is
minimal change. The name minimal change comes from the fact that on light microscopy, the kidneys look completely normal.
Yes,
right?
sir. Yes, sir.
So if you take a kidney of someone who doesn't have any disease and examine it under a light microscope, and you take the kidney or kidney biopsy sample of someone who has minimal change disease and examine it under light microscopy, you will not see any difference between the two. All right. That is why it is called minimal change disease. But when you do an electron microscopy, then you will see abnormality. And what is that abnormality?
Sir, effacement, podocyte effacement.
Yeah, what is the meaning of effacement?
Effacement means, sir, in the food process. The food process actually there is food process, but there is flattening of food process.
Well, normally, you have the glomerular epithelium, and the glomerular epithelium is covered by podocytes and their food processes. Podocyte is a cell which has a body, and then from the body a number of
food process,
a number of projections come which wrap around the capillaries, and so they are called food processes. And those food processes are normally very discrete, and you can see gaps between two food processes.
Yes, sir.
But in minimal change disease or podocytopathy, those gaps disappear, and it looks like the food processes are all touching each other. So that is what is called effacement or fusion of food processes.
Fusion.
So that is the electron microscopic appearance of minimal change disease. On immunofluorescence, which is the third way in which you examine a kidney biopsy, again, you may not detect any abnormality in minimal change disease, but some minor abnormalities can be detected. And what are those minor abnormalities? Do you know?
In minimal change?
Yes.
Yes, sir. Some variants are there, like there is maybe C3 or some IgM deposit maybe there.
Not C3, IgM. You may see IgM, some IgM deposit.
C1q, C1.
Yeah, C1q, which may not be inconsistent with the clinical diagnosis of minimal change disease.
Yes, sir.
Right?
Yes, sir. Yes,
but whenever there is some immune deposit present in otherwise minimal change disease patient, there is always a risk that there may be a secondary cause.
Yes, sir.
right? Or that the prognosis may
এখন তো
not be
হলো
as
এখন
good.
হলো এখন হয়েছে ভিডিও তাই
Yes, sir.
That's important. Right. So what are the other possible causes of nephrotic syndrome at the age of 15 years? You said minimal change, you said FSGS. Anything else? Less common, but still can be present?
Sir,
Membranous nephropathy.
membranous nephropathy can present.
Can be present.
Can be
It's
present.
yeah, it's not common at this age, but
Yes,
it
sir.
can still be present. It is consistent with this clinical presentation. I
Yes,
think
sir.
clinical presentation 3 weeks and the way this patient has presented with rapidly oncoming anasarca, ascites, pleural effusion, etc. I think overwhelmingly minimal change disease is likely to be the
Likely,
diagnosis,
yes, sir. MCT.
right?
Yes.
And which is what your kidney biopsy has also shown. So minimal change disease.
Yes, sir.
So how will you treat this patient now?
Sir, as the adult case, 15 years now, start to 2 milligram per kg dry body weight, not more than 80. We started actually 60 milligram per day for at least new for 6 weeks, total 6 weeks. Then sir, within 2 weeks, his symptom improved, like his albuminuria decrease, edema improved. And when 6 weeks completed, then started 1.5 milligram.
So let's say this child, you started steroids and the proteinuria disappeared in 1 week. What will you do?
Continue steroids, sir.
For
Same
how long?
doses. For total 6 weeks.
Yeah, continue full dose steroids for 4 to 6 weeks. All
4
right.
to 6 weeks.
So
Yes,
now there is some evidence to suggest that even 4 weeks may be enough. But
enough, yes.
and since if this was a 30-year-old person, I would definitely give for longer duration.
Longer.
But in a 15-year-old child who responds very quickly, I might even start reducing the dose after 4 weeks. All right.
Okay, sir.
So you give full dose for 4 to 6 weeks, and then you give alternate day.
Alternate day or 1.5
therapy.
milligram per week.
Right. And then you slowly taper it off
Slowly
over a
taper,
period
yes.
of time. So that's the standard approach.
Protocol,
And when you
yes.
give steroids, please do remember that given the fact that the risk of infection is always high, you
Yes, sir.
must give prophylaxis against the common infections.
Yes, sir.
So we will typically give prophylaxis against pneumocystis infection. So we give
Cottonmouth,
Septran.
sir.
Yeah,
Cottonmouth, yes, sir.
Septran, definitely we will give Septran
Yes,
to
sir.
this patient. And anything else you will give? You will probably give some symptomatic treatment, such as diuretics. You should advise salt restriction, at least in the initial part of this patient's illness before the proteinuria response. One of the ways to ascertain use of protein response is by asking this patient to do dipstick urine protein test at home. And when you determine that the patient has gone into remission, how do you determine that the patient has gone into remission?
Sir, remission is defined by 3 consecutive Bonley sampling. Then when less than 2.2 protein creatine ratio, or albumin less than albumin, serum urine albumin test.
Yeah, so the improvement in serum albumin will take time.
Yes,
But
sir.
once you have shown that for 3 consecutive days, if the urine protein is nil, then you
Yes,
might
sir.
say that the child has entered
Go into remission.
clinical remission. All right.
Yes, sir.
Serum albumin will take longer time to recover.
Yes,
I think there have been some other comments also. For example, use of ACE inhibitors. ACE
Yes, sir.
inhibitors we
Hypertension.
typically don't use when the diagnosis is minimal change disease, because we expect these patients
Improving
to
with
respond
steroid,
very
this
quickly,
improve.
right? So we
Yes,
give
sir.
only steroids. But if
Only
there are
steroid.
other diagnostic possibilities in mind, which are less likely to respond to steroids, then you will give ACE inhibitors.
Yes, symptomatic. Yes, sir.
And someone has said that you should give calcium and vitamin D for long-term steroid therapy. Yes. So again, calcium and vitamin D, you will not necessarily give if you expect the patient to respond quickly, like minimal change disease. The last question is, any need of routinely giving statin and anticoagulants? So no need to give statin again if you expect
Less
the
than
patient
18
to
years,
respond
no.
quickly.
Yes, sir.
But if the nephrotic syndrome is due to a condition which is not likely to respond quickly, then of course we'll give statins. Anticoagulant is very
Yes, sir.
important question. So, anticoagulant again, anticoagulant is not likely indicated in minimal change diagnosis. But if someone is severely hypoalbuminemic, for example, if the serum albumin is less than 2,
2.8.
less than 2, then we
2,
will
yes.
want to give anticoagulation, especially if the patient is bedridden because of some reason or the other. Otherwise, you don't give anticoagulation in this situation. All right, I think we are coming to the end of our time. Any other question, Dr. Pinaki or Dr. Shibendu?
Sir, this is one issue, that is, as it is, you are discussing the MCD, because MCD has a two way of presentation. One is a MCD in adult and MCD in child. So one should know what are the difference between the adult MCD and what is the outcome and approach to the patient, because many of the patient, at least 10-15% patient, they in an adult geriatric group also presented as MCD.
Right. So what is, Dr. Kaushik, did you get the question from Dr. Pinaki Mukherjee?
Yes, sir. Difference between MCD in children and adult. I said some prognostic marker are there in age wise. If in adult case MCD is not so means in children MCD is very much responsive to steroid, but in adult not so much responsive to steroid MCD.
Yeah, so you are right that steroid responsiveness is less in adults, and you have to treat these patients for longer duration also to achieve
and more relapse is more in adult.
Well, not necessarily true. Relapse is more frequent in childhood MCD as well, but you may need longer duration of treatment, and the prognosis is relatively worse in adult nephrotic, adult minimal change disease.
Much more prone for AKI, much prone for ASRD, much prone for convert. There is this progression is much more because kidney aging is there in this group of patient. So relapse rate is not so much common, but hypertension is much more common in case of elderly group.
Though, can I make one comment? Very, we frequently find that's very common that steroid is very long. The scope of immunosuppressive therapy, certain types of NCD, particularly in elderly age group or we should start for or thinking that recurrence of the symptoms, recurrence of the disease, steroid, longer steroid causing toxicities and all these things. Does it come as the important issues in treatment of NCDs? What do you think?
So, Shibendu, I missed part of your question. I think you were.
Yeah, no, what I'm telling, in some group of, most of the children, they do well, but the children, it's a younger age group, I mean, higher age group, they sometimes may not respond well, or and sometimes who go for steroid for a longer time to decrease the, I mean, the remission, I mean, to have a better remission. So do you think that we can spare the steroid to other drugs in which part, I mean, which percentage and what are the population when you want to go for non-steroid therapy? I mean, steroid, but
understood. So I know we have just 2 or 3 minutes now. So the primary treatment of minimal change disease is almost always with steroids. But in case someone doesn't respond, which means that they are either steroid resistant, or if they respond but they develop relapses, they're frequently relapsing, or they're steroid dependent, then you might want to think of alternative treatment possibilities. If someone is responding, even if someone responds and relapses once in a while, I think you can easily repeat steroid dosage, right? But if someone is responding but relapsing more frequently, or someone is steroid dependent, then of course we consider the use of steroid sparing agents. And now we have a number of steroid sparing agents, which include cytotoxic therapies, alkylating therapies like cyclophosphamide. We can use calcineurin inhibitors like tacrolimus and cyclosporin, or we can use B-cell targeted therapies like rituximab. And whenever you want to, whenever you want to use any of these therapies, it is always a good idea to consult with a nephrologist, because all of these, come with their own risks, and it is best to do a risk-benefit analysis.
Yes, sir.
Thank you. Thank you. Thank you very much.
Professor Jha, I have one question to you.
Yes, sir.
And this question is hunting me for many years. The diameter of albumin is less than the diameter of the renal pore size.
Right.
So God has created, why this mystery? If the things would have been otherwise, we have no minimal change disease.
So, so Dr. Kaushik, do you know, can you answer Dr. Ganguly?
No, I think Vivekananda, you answer. Kaushik will hesitating. Yeah,
Please remove your screen. Remove your screen.
yeah.
So very important question, Dr. Ganguly. So there are a number of reasons why the glomerular barrier, permeability barrier functions. So one is size selectivity, right? So that there is, as you say, that the size of the pores is larger than the size of the albumin molecule. So if size was the only determinant of excretion or filtration, then albumin molecule should have passed through the filtration barrier and come out in the urine. But size is not the only barrier. There is another thing called charge selectivity. So the glomerular base or glomerular filtration is also, it carries a negative charge, and albumin molecule also carries a negative charge, and
Repels each other.
they repel each other, as you correct.
Yeah.
Absolutely. So this is the old principle of physics that we all, you and I, we all read in our school days, right? So that principle applies in the kidneys also.
Thank you.
Thank you.
Thank you, sir.
Okay. Pinaki, do you have anything to add, or do you like to have any comment? Since
Yeah, sir. Because nephrotic syndrome in nephrology is a real vast subject, and there's a lot of discussion regarding the diuretic use, edema management, and diuretic resistance, aldosterone escape. There are a lot of things are important things to discuss. But it will take another 2 or 3 classes. I think definitely. I think Dr. Jha again will give us time to discuss in different part of the nephrotic syndromes and the MGN and other things. So every time, so when we join and we take in class, every time we increase our knowledge from the Dr. Jha. Always there is or give us extra benefit, extra input that is not even in the reading the book. So hopefully we'll get similar kind of input. And also, as I'm a chairperson, I have to stop at a particular point of time, because there's a lot of good responses from the PGTs. Even all the DM and DNB PGTs also, they're watching this classes also. So I will complete this session for the last comment from Dr. Jha.
okay, Dr. Jha, you give your comment. Then we have a little bit other formalities also.
No, thank you, Dr. Pinaki and Dr. Banerjee, and again Dr. Jyotirmay Paul and all the other colleagues. I have nothing else to say. It's always a privilege to interact with students, and again, I'd like to thank all of you.
Thank you, sir.
Okay, thank you. Now I request Dr. Rothin Sarkar, who is one of our course directors, to give a vote of thanks on behalf of ICP West Bengal branch and also API West Bengal branch.
Thank you, Amulda. Now, on behalf of the ICP West Bengal and West Bengal API branch, it's my pleasant duty to thank, first of all, Professor Jha for his nice deliberation. He has given us very deep insight into this nephrotic syndrome. Then I will thank Pinaki for interacting with the PGT, Kaushik, Samanta. And then I would like to thank all my colleagues and the other PGTs who have joined this master class. And I will also thank our office staff for giving us this logistics. And now over to Dr. Amal Banerjee.
Okay, thanks to my special thanks to Dr. Jha for your superb discussion on nephrotic syndrome. Anyway, any good thing has an end at any time. Anyway, we expect your teaching in future in our forum. Now, with this word of appreciation. I adjourn this master class till next Sunday. That's